thank MedSynapse and the team for giving me this opportunity to talk to you on UTI, the surgical causes. I am Dr. Mohan K. I'm a pediatric surgeon basically and interested in pediatric urology, and I'm practicing since 1985, and I'm Professor Emeritus at the moment in Amrita Institute of Medical Sciences, which is a university hospital in Kochi, Kerala. And we have training programs both in pediatric surgery as well as pediatric urology. I will be limiting myself to about three scenarios today for want of time. Now, if you take all surgical causes, the main culprits are stasis, which produce overgrowth of bacteria and leading to infection, high pressure in the system, producing mucosal ischemia, and any ischemic tissue is a good culture media for bacteria, so that leads to infection. Then vesicoureteric reflux, again, there is stasis because the urine keep going up to the kidney and then back to the bladder and again. So that again leads to urinary tract infection. I'll start with common things like posterior valve. These are two valves that is coming from the verumentanum and getting inserted anteriorly. What happens is when the child tries to void, these valves fill up and obliterates the lumen. And that obliteration leads to detrusor and duodenal hypertrophy. And this produces a high pressure in the bladder, again produces bladder wall hypoxia, and that leads to extracellular matrix. And also mucosal ischemia, as I said earlier, produces infection and bacterial colonization. So you land up with a thick bladder, which is mainly extracellular matrix and fibrotic, small, high pressure bladder. Now you look at this MCU, the one on the top is a normal MCU. You can see the posterior urethra there, you can see the nice contour of the bladder. Whereas if you look at the one below, you see the dilated posterior urethra with a cutoff, and also there is a high pressure bladder with multiple diverticuli, a small capacity bladder with multiple diverticuli. So this is a scenario, and this is what is causing the problem. So how do you manage initially? All of you know, hydration is the main thing to do first, not catheterization. Because these babies are, especially if they are coming from home, are severely dehydrated. And if you put a catheter in first, what happens is they go into post-obstructive diuresis. And what causes it is, one is osmotic diuresis, because a lot of urea comes into the tubules, and the urea is hyperosmolar, and that attract more fluid into the tubules. So the child produces a lot of urine. Another thing, what happens is a renal reperfusion. Because when the child is obstructed, there is high pressure in the calyces, the high pressure in the medulla, and the endocortical areas. So there is obstruction to the afferent and efferent arterioles of the glomeruli. And that reduces the blood flow to the kidney, reduces the urine production. But the moment you put in a catheter, that pressure is taken off and there is a reactive vasodilatation. And that leads to increase in the single nephron glomerular filtration rate, or there is a lot of production of the urine. And you will notice that both these conditions are not controlled by antidiuretic hormone. So even if the baby is dehydrated, still they will produce a lot of urine. Baby goes into severe dehydration and pre-renal shutdown. Now, how do you give IV fluids in these children? You cannot go by the standard formula of 100 ml per kg, 120 ml per kg, because some kidneys will be producing a lot of urine, some kidneys may be totally destroyed and may not be producing any urine. So initially when the baby comes, you can give 1 or 2 doses of half saline. You don't give potassium because you don't know what potassium level is in kidney failure. So you give dextrosaline 1 or 2 bottles till the dehydration is corrected. After that, you go by urine output plus insensible loss. Now, urine output is like if they, a 3 kg baby, this ml produces 10 ml, and next hour you add the 10 ml plus 0.6 ml per kg. So 3 means 1.8 ml. You add on to that. So you give 11.8 ml the next hour, then follow up the next hour again, you do the same thing. Now 0.6 to 0.67 ml per kg per hour is easy to remember. And if the baby is premature or baby is on phototherapy, you may have to give 0.7 ml, otherwise 0.6 ml per kg per hour. Now, in about 72 hours, most of the kidneys regain the concentrating ability. At that time, you give IV fluid, the IV fluids what you are giving, you reduce it and see that the urine output also reduces. If the urine output reduces, that means the kidney has regained the concentrating ability. Then you can reduce the IV fluid further and come to the normal maintenance fluid. What is the surgical management? You can do a cystoscopic fulguration or incision. You can do it with laser, or you can use a valvotomy, which I invented. Now, fulguration or valve incision with electrocautery. You put a bug bee and cauterize, has its own problem, mainly strictures. Because you see, you are using electric current inside the small urethra, and when you apply the current, there is heat that is produced, and this produces strictures of the urethra. And if you accidentally damage the external sphincter, you will end up with incontinence. Now, the incidence of strictures is reported anywhere from 3.6% to 50%. So that was a main problem, and that's why I invented this valvotomy. It is made of hollow tubes, but the tip is beveled in such a way that it doesn't catch anything other than a floating valve. So I gave it for trial to my friends in India. We had 78 cases in total with only one stricture, which is much better than a fulguration. We have published our experience of 7 years. My name is not there because they were using my valvotomy, and they found that incidence of stricture is very less when you use valvotomy, because the reason is that it doesn't use electric current, so there is no heat generation. We are just, it's like a cold knife. We are just cutting it with the valvotomy. Now, there are publications from other countries also. This is from West African Journal of Medicine. This is another publication, Journal of Pediatric Urology. And this is again from India. So it's well appreciated and used, a lot of places in the world. Now we're coming to ureter. Ureter is grossly dilated because of the pressure. The pressure in the bladder is transmitted to the ureter, so it dilates. And when it dilates, it loses the ability to peristalsis, because it has to, the lumen has to be obliterated fully for the urine bolus to move forward. So when that doesn't happen, stasis occurs, infection follows. And when the bladder pressure becomes so high as to overcome the anti-reflux mechanism of the vesicoureteric junction, you get a vesicoureteric reflux and renal damage. Now, most of this VUR, because it's secondary VUR, subsides in 6 months' time. So it is prudent to wait for 6 months to see whether the reflux is improving or not. You have to also take care of the alpha-adrenergic impact on the bladder, because as I said earlier, the bladder wall and the bladder neck is hypertrophic. And because it's hypertrophy, even if you remove the valve, still the obstruction at the outlet continues. Now, it is alpha-adrenergic receptor that controls the bladder neck. So if you give an alpha-adrenergic receptor blocker, it relaxes the trigone and the proximal urethra. And so the voiding becomes better and the voiding pressure becomes low. So that it results in resolving of the, vesicoureteric reflux if it is or at least upper tract dilatation. We were the first one to try it, the effect of alpha-adrenergic blocker on posturethral valve. And so this was published way back in 2009 in Pediatric International. And what we found was in 95% of cases, there was a significant reduction in the post-void residue. So we still continue to use that. You may need anticholinergic if there is evidence of detrusor hyperactivity, like small frequent voiding, UDA showing hyperactivity. You give oxybutynin is widely accepted approved for pediatric use. And nowadays, sulfasalazine also is approved, so you can use either of them. When to intervene? When the DMSA shows increasing renal scars, that's the time to intervene. Otherwise, this is a secondary reflux. Even if you wait for 1 year or 2 years, if there is no renal damage, then you can wait longer and this refluxes will subside. Now, this can be taken care of even in the fetal time, in the intrauterine period. I'll just show you one value. I'm not going into the details. Now, this is done under local anesthesia. I'm injecting a little saline into the mother's abdomen. And after this, you go with a curved fetoscope. As you go in, you can see it going into the bladder on the ultrasound. It's going into the bladder. As soon as it reaches the bladder, you put in a telescope. This is about 1.2 millimeter telescope. You go into the urethra. And there's a sharp angulation there. So this cannot be done beyond 24 weeks of pregnancy. 18 to 24 weeks is ideal time to do this. And you go down till you find a obliterating membrane. You make sure it's a membrane by pushing with your laser fiber. Because you can also mistake it for the posterior urethral wall. So make sure it's a membrane, it's a diaphragm sort of thing. And then you apply the laser energy, make multiple holes. And when you make this multiple hole, you join them together. Your intention is not to, destroy the entire valve or the entire membrane. You make a sufficient hole, sufficiently big hole so that the urine can flow freely. Now, postnatally, you do a cystoscopy, and if there is residual valve, you can take care of it. You pull out your fetoscope once the thing is done. The mother is put on tocolytic for about 3 or 5 days, and then discharge home. Now, there was a large study comparing fetal cystoscopy and valvular ablation versus vesicoureteric shunting. Remember, vesicoureteric shunting was the first one that came as a treatment for posterior valve in intrauterine period. Now, when they compared, they found that fetal cystoscopy and valvular ablation improved both the renal function as well as pulmonary function, resulting in a better 6 months survival. While as vesicoureteric shunting had improved the pulmonary outcome, but with no effect on the renal function. So as of now, the best thing to do is a fetal cystoscopy and do a fetal valvular ablation. We come to adenophyrosis. This is a block at the pelvic junction, which leads to stasis, high pressure in the pelvis, and resulting in UTI and damage to the parenchyma. This is a large pelvis that you can see. This is a large pelvis, and this is a narrow ureter. From here, ureter is big. So this narrow portion, we excise the redundant pelvis also like that, and then anastomose the ureter to the pelvis. That's what we call Anderson-Irons reduction pyeloplasty. It can be done either open or laparoscopic. You can also do in a very small babies, like 1 month, 2 month old babies. You can do a laparoscopy assisted retroperitoneal pyeloplasty. This is how it is done. You put 3 ports. You dissect out the pelvis, then make a small incision, 2 centimeter incision, and bring out the pelvis and the ureter out. And then, as I said earlier, resect the pelvis and the upper part of the ureter and the anastomose. You will end up with a small scar like that. And then we published our technique in 2009, and we are still doing it for small babies. Postoperatively, we do a DTP after 6 months. Remember, UTI can occur as long as the dilatation persists, and the dilatation will persist because this is a congenital dilatation. It's never going to be looking just like the normal side. So there will be some amount of dilatation. The parents has to be warned that UTI can still occur, and if that does, you need to give antibiotic and treat that. Now we come to vesicoureteric reflux. Remember, these have a genetic predisposition. So if one of your patients have EUR, you should screen the siblings for the same. Clinical presentation is usually with multiple urinary tract infection, and you do a micturated cystourethrogram to diagnose that. Now, if it shows reflux, then you do a DMSS scan. And because the DMSS scan will tell you how bad the kidney is affected. If the kidney is not affected much and the reflux grade is not great, like 3 or below, then you can safely give conservative management to see whether your reflux will subside by itself or not. But if the DMSS scan, serial DMSS scan shows increasing scars in spite of conservative management, then we need to go in. There is no age bar. There is a myth, earlier that you should not operate this before 1 year of age, and that's a myth. And if your aim is to prevent the kidney damage, and whenever it occurs, if you think it's going to occur, then you need to intervene. How do you manage? As I said, conservative is the mainstay. Antibiotic prophylaxis, there are clashing opinions. Some people say it's not very useful. If you look at the Cochrane review, that says it makes little or no difference to the number of repeat symptomatic and febrile UTI in children with EUR. Now, there was a last study, reverse study, which concluded that antimicrobial prophylaxis was associated with substantially reduced risk of recurrence, but not of renal scarring. So the opinion is differed. It is up to the physician to decide whether to give antibiotic or not. The only thing is, if you give antibiotic, the parents will remember that the child have a problem. The child gets some symptom, they will come back for follow-up. That's the only indication that I see really relevant in this case. Now, if you give alpha blocker, that will relax the bladder sphincter, as I said earlier, and that the 60% decrease in the reflux grade. So nowadays we give treat them with alpha blocker. Terazosin is what is FDA approved. So that's what we do. Now, endoscopic management, you inject, Deflux or Dexel. There are various trade names. It's a bulking agent in subureteric. And then you get about 62.5% to 79.7%, cure rate with multiple injections. The problem in India is a cost. It costs about 45,000 per ml. So if you want to do both sides, about 90,000 rupees with a 70% success rate. Some people say if you do a double heat, they inject into the ureter and outside the ureter, then you get a 93%. But there are many articles to substantiate this. So operatively, you can do a laparoscopic extravesical reimplantation. Here, the surgery is done from outside the bladder. You divide the detrusor, make a tunnel, and bury the ureter inside. But the problem here is a nerve injury, because the nerve plexus that controls the bladder function is at the vesicoureteric junction. So when you are operating in that area, there's a possibility that create a neurogenic bladder. So laparoscopic extravesical reimplantation is not recommended for bilateral cases, although people are still doing it in unilateral cases. We don't know whether they are creating occult, neurogenic bladder, which may manifest later on in life. We do not know. Now, viscoscopic reimplantation is same as open. You do it through the bladder. You do a trigonal reimplantation, and it is as safe as an open, and success rate is also same as an open. And that's what we do mainly, and it doesn't have any problem with the nerve damage. Now, we published a simple technique of torque positioning in uterine reimplantation. This is in 2011, Pediatric International, and it's a simple technique in which you anchor the bladder to the abdominal wall and then put the ports. Long-term effect, Jacobson and associates studied the outcome of 30 patients, and they said 10% of these patients had progressed to end-stage renal disease, 23% hypertension at the time of follow-up. So these patients has to be followed up lifelong, and once they graduate from the pediatric to the adult group, they have to be told that you should check your BP, you should check your renal function, even in the adult group, especially in females if they are going to get pregnant. Thank you.